All right, thanks for coming back for more clinical cases. Again, we're going to open up the ultrasound scrapbook and go through some great cases that have come up over time. It's getting close to the holidays, time of reflection, time to look back and see what we've done and where we could potentially go. So see what we have here. Oh, look at this, perfect timing. This was a change of shift case. So you come on, someone else has been working on someone, and you get to pick them up. I always just believe everything that they tell me, the exact diagnosis. I don't question anything, and I just go.
That's a good way to do it.
And so this is a 38-year-old male with a history of palpitations. And they thought he had holiday heart. Holiday heart, right? What?
Sure.
Just holidays.
Too much drinking.
Sure.
Yeah. Heart goes
or
out of rhythm.
not enough drinking, one or the other.
Yeah. So it seemed pretty innocent. Okay. Young guy. I mean, what could possibly be wrong? Young people don't have bad hearts.
No.
Okay. So palpitations for 2 weeks. Came in, EKG, AFib with RVR. Tachy in the 140s. Drinks about 10 to 12 beers per day. You can't drink all day if you don't start in the morning. So they felt like he had holiday heart. Gave him some cardizem, a couple liters of fluid. His rate got better. But now, a few hours into this, he is really dyspneic and hypoxic. What do you think?
Did they look at his heart before they did all that?
Nope. No, just some EKG and some labs. MAG was normal, K was normal, normal hemoglobin.
Well, I think there's going to be something else wrong. Otherwise, he wouldn't be in the scrapbook. But I don't like that diagnosis of holiday heart with that duration of drinking. It's usually an acute high exposure that does it. That's why they call it that. You get it on New Year's Eve and Christmas Eve.
Oh, come on, guys. How often do we see AFib with RVR?
But I mean, anybody
It's a
with
common
any
diagnosis.
heart problem, and you have an ultrasound machine in the heart, you should look at the heart and see how it's
Well, what about
functioning.
that? What about what do we use?
Stethoscope?
Yeah.
Yeah.
And what about that?
That's a thing of the past.
Apparently no murmur. Didn't have murmurs.
This is why stethoscopes are so terrible, because I'm sure his heart sounded irregular.
Well, listen, they were cutting edge in 1843, right?
Yeah.
But I think we moved beyond the stethoscope. So let's go.
This is a common presentation. AFib with RVR.
Oh,
Whether it's a
absolutely.
young person, an old person, it's something we see all the time.
Yeah.
Yeah.
But it's
And-
not the hypoxic and respiratory distress is not common.
I think there's some iatrogenic component here. Got a couple liters of fluid.
Okay.
And so you get to pick them up. So 92 over 60, pulse 88.
15 liters.
So, I mean, the rate's better. So, I mean, you brought the rate down, so I'm sure whatever was wrong will get better. They're not doing so well, though. 72% on 15 liters.
So it's time to look.
And so they're done. Into their shift.
Yeah.
Here you go. Good luck. So, I mean, what's the next move?
Look at his heart and see what
You have to.
is going
Okay,
on.
let's see what we got. That does not look like a good 38-year-old heart, right? So we got poor LV function. Looks like some LVH there. RV doesn't look big.
Would you show it again, please?
You bet.
So not good for a normal 38-year-old, but a distressed 38-year-old, that's extremely bad,
Yeah.
right?
And then we got the IVC over there. Definitely got plenty of preload by now. So it looks like biventricular failure actually there. And so just a few more images, right? See a little bit of pericardial effusion, depressed LV function. EPSS is really
Terrible.
quite large
Yeah.
there.
This is
And you
not,
see that
this
little
is
bit of
not like
pericardial
a
effusion.
real acute process, right? I mean,
Well, it may be. You could have
Yeah,
a
it takes
myocarditis or a viral myocarditis with this.
yeah,
doing
but
this.
it's at least several days.
Yeah, absolutely.
He'd had
probably
had
more.
palpitations for a few weeks.
Yeah.
Yeah,
He's probably in heart failure for a couple weeks or more.
absolutely.
So AFib with RVR with low EF. Diltiazem's usually not my first go-to. And certainly 2 liters of fluid, no style points for that either.
Yeah.
And there you can see in the short axis, same things. And just for good measure, a little bit off axis apical view. Probably should have started with the lungs, but this is a case from a bygone era. And there are all kinds of pulmonary edema right there, and that was diffuse pulmonary edema all over. So you come in, you pick up this person, it probably takes 3 minutes to do this exam. And so BiPAP, diuresis, eventually ended up having kidney injury, got impella, dialysis, ungood for a 38-year-old gentleman. And certainly the early portion of the care didn't help a lot.
But the sad thing is that's how most people practice.
Well,
Even,
it's sort of
how many years has it been since POCUS has been around?
1986.
So
Another couple, 25 years, we'll be right in there.
Maybe.
No, I don't mean to be cynical, but I mean, you do see this, and especially with that volume loading, especially with that, jumping to that as early therapy without taking a look to make sure the heart can even sustain that. But my question here is, what's his ultimate etiology?
Yeah, I don't even recall all these years later, but
It's a crazy
clearly
case.
had some LVH there, got a cardiomyopathy, had the pericardial effusion. So frequently, I think it's not uncommon to have a virus happen beforehand. The LVH was definitely unusual in that presentation, but
So this reminds me of a conference where the question to the presenter was, how come these always seem to come in just on your shifts? And the answer is they don't. They're on everyone's shifts.
I thought I was just unlucky.
They're there, they're just not finding them.
yeah, I mean, if you use ultrasound a lot, you find things like this all the time.
Yeah,
Yeah.
Sometimes in pretty young people.
yeah.
And just taking a quick look, it takes a few seconds really between the lung ultrasound and doing it before they go into decompensated heart failure,
Sure.
right? I mean,
Sure.
they were already in a little bit of a problem, AFib with RVR, and then what you did caused it's just no style points, potentially could kill the person. He did respond quite well, but
Boy.
I mean, you should be doing a cardiac ultrasound on everybody that has chest pain or dyspnea. Some people use it on everybody that they just use it on cardiac arrest, but they neglect to use it on chest pain and dyspnea, which is like,
Yeah,
I'd
more
rather
important,
make the
bigger impact.
diagnosis before they have a cardiac arrest
Sure.
rather than after. So, yeah.
Yeah,
This is
the
an
impact
example
that,
of, like,
on a
you
case
use
like
it.
this is huge.
Yeah.
So it's a good case.